I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin. I'm thrilled to be joined by Dr. Craig Miller. Craig is past president of the AATS and somebody who's well known to lots of people for good reasons, Craig. So thanks for joining me. Let me ask you, the whole concept of volume and quality and durability, those are big words, but where do we stand with this concept of volume of procedures leading to quality?
Well, that's a great question, Randy. Randy and I have known each other since the 1980s, when Randy was an Echo Fellow and Rich Pop was developing Echo.
1970s.
70s, yeah. Boy, we're both getting old. That's a long time, and we've come a long ways, but your question's very poignant and very timely. And for example, with TAVR, it is a hot potato as CMS decides what to do with the NCD.
Right.
And whether these TAVR valves are going to be sold like Foley catheters in every hospital in the country, which a lot of companies want, or whether it's going to be restricted and looking for the best outcome for the patient is up in the air right now. And very polarized discussion, as you might imagine, with the patients' advocates and access industry, of course, and then those of us who are kind of vox clamantis in deserto these days, really trying to look out for the patient and ensure somehow quality. The number game has been around for a long time, and I think everyone will admit that for any complex procedure operation, there is a volume quality outcome relationship, and it's probably steeper the more complex it gets. However, trying to prove that, let alone implement it and then enforce it on a nationwide basis in a capitalistic society may well be unrealistic. I hope not, but might be. TAVR is a good example, and now the new numbers are down to 50 per year for an established center, both open AVR and TAVR, to keep both sides current and be able to give the patient a fair shake when it comes to the other buzzword today, which is SDM, shared decision making. Well, it's pretty hard to give the patient the full story if you only offer one or the other.
Right.
And you got to do both, and you got to do both well.
Right.
When it comes to mitral, which is the reason for this meeting, it's even more of a quagmire. The guidelines in 2014, updated in 2017, the European guidelines, they now talk about a Class 2B indication for prophylactic mitral repair for those with severe mitral regurgitation, even in the absence of triggers or symptoms. If it has a very high likelihood, 95% chance of being repaired, and if it's durable. But none of the guidelines writing committees have ever defined what durability means. And I'm afraid they don't care. So most patients will come to a surgeon, or in California, several surgeons shopping, just like in Atlanta maybe, and they'll say, "Can you repair it, doc?" And it's the absolute wrong question to ask. What they should be asking is, how long will a repair in your hands, in my case, last, doctor? And we just don't see them asking that question. And Dr. Adams, who is the father of this conference, and everyone's saying 99% of degenerative primary MR valves should be repaired. Again, I think we're missing the mark, and we should be more introspective and not measure ourselves by how many we repair, but what happens to the patient 1, 5, 10 years later. And that's the other bone I have to pick with the guidelines committee. I've got several quibbles. And everyone talks about durability, but they don't define it. And even in a socialistic society, Great Britain, in 2006, Ben Bridgewater, Frank Wells, who is here today, Bruce Kehoe, who is the medical director of the NHS, after that tried to implement standards based on volume, number one, and it was 25 mitral repairs per surgeon per year. If you don't do at least 25, you don't get paid. Each hospital, you had to do at least 50 per year. mitral operations, repair and replacement. And then they had audits of 1 year and 5 year audits of Alive and echo,
Freedom.
recurrent MR, or mitral stenosis, which had been created by a too small a ring. And even in the NHS in Great Britain, a socialist country, that failed to ever gain any traction. Each NHS trust thought they were an independent fiefdom and the money didn't follow the borders.
You're giving me a depressing story here. You tell me. So it's not realistic that we're going to get to...
It is realistic if, number one, we put our money where, and by our money I mean we have finite resources in this country, every country does, and futile procedures and poor procedures that fail aren't doing anyone any good. So if we police ourselves, not just in terms of numbers. The average number of mitral valve operations in each hospital is 5 or 6 per year. How can anyone learn how to find the mitral valve, let alone repair it, like you've seen in some of these videos?
Right.
That's just not going to fly. If you take 18,000 mitral valve operations in the U.S. each year, divide by 1,200 hospitals doing cardiac surgery, that's 15 per hospital per year if it were divided equally. And it's 3.6% of all the cardiac operations we do, so why take something that spreads so thin, dilute it even more, and it's almost guaranteed to backfire in terms of durability and quality.
You sound like you're not going to have many friends in the world.
It's a good way to lose what few friends I have left.
So Craig, do we create reference centers? Do we create centers of excellence? Is that, I mean, what do we, I mean, because it's rampant across all, I mean, mitral valve obviously, but in a lot of areas, what do we do?
It's rampant in every facet of cardiology and cardiac surgery, and the problem is the God Almighty evil of the dollar. And it's sad that we let that take priority over what's best for the patient.
Let me I agree with you wholeheartedly. Do we create reference centers for mitral valve where if it's anything that's, quotes, complicated or hard, that's where the patient should go and somebody has to make that decision?
The only one who will make it honestly will be the payers if they have a 1 year, 5 year quality metric to weigh upon which reimbursement is predicated. Without the midterm quality metric, everybody's flying blind. The reference center concept is, talk about a radioactive hot button, because everyone around the country claims they're a reference center and a referral center, and I can do it better than Carpentier. But it's not all self-serving. And those thoughtful leaders who are trying to implement this are really trying to put the patient's welfare first.
Which is, yeah,
absolutely. And that's what's so important. But making that happen is very tough. And the only one who can make it happen is the payers.
Will societies do that with working with the payers? But that's hard because societies have members.
So our societies, our professional societies, that's like me asking you if the ACC will tell their constituents you can't have TAVR in every single hospital, and it will never happen.
Yeah.
Our societies serve our membership. We have to go beyond that, and we have to be altruistic, we have to be unselfish, and we have to recognize that you cannot do procedures of any sort, interventional, open, surgical, and expect to attain midterm, long-term, excellent results, durable results in the mitral valve without stenosis, recurrent MR, unless you do a bunch of them and you learn.
No.
And we've heard this morning that applies not just to the complex mitral repairs, but also the so-called middle scallop, posterior leaflet, fibroelastic deficiency, which everyone thinks is a slam dunk and anyone can do. But as you saw this morning, some of those easy, simple cases don't turn out to be so easy. The best paper, or the most interesting example, which illustrates your point, just came out from New York State by Hannon.
Right.
And they had 41 hospitals, and they looked at their mitral volume, and they parsed it as best they could for degenerative mitral regurgitation. And only 80% were repaired. Even though these were asymptomatic people with normal left ventricles, no symptoms, no triggers, the quote asymptomatic prophylactic mitral repairs that the guidelines in 2B now allow us to do. but the guidelines say it has to be 95% repairable. Why is it only 80%? And some of that would I have to kick back to you. Echo is not perfect in determining repairability, durability of repair, and particularly with regard to calcification. You can get tricked and get in there for a simple P2 prolapse and
have a big bar of calcium.
Find yourself in trouble. So, but it's really up to the payers because the societies won't do it or can't do it.
That's a difficult situation, but you're really highlighting the importance of durability of outcome, doing the best job for the patient. So I mean, it makes sense, and I'm it's people like yourself that's keeps pushing the message, because I think it's important, and the message hopefully will filter up.
Well, the consumers then are going to have to sober up, because I don't think we can look to our professional societies to.
Well, that's one of the key things. I've been a big proponent of consumer education, and I think that's one of the. It's a difficult message, but it's something to do. Well, I really appreciate you keep pushing the message. You're not going to shoot the messenger.
It's a good way to lose what few friends I have left.
No, but you're doing what's right. You're doing what's right for the profession and for the patient. So.
But I'm also being realistic, and I'm not sure this quest is realistic. Take, for example, New York State public reporting of all cardiac surgery. Well, what's the strongest determinant of where they go now that outcomes are public? Surgeon and hospital outcomes. One of the strongest predictors of where they're going to go is their zip code. They are not going to travel.
It's a difficult situation. Well, listen, keep going. Okay.
Thank you. Good to see you again.
Enjoyed seeing you as
always. Good to see you.
And thank you for joining us.